Hello and welcome. This is a presentation of my article, Changes in Peak Expiratory Flow after Osteopathic High Velocity Low Amplitude Manipulations of Vertebral Segment T1 till 5. In this study, the intervention is a high velocity, low amplitude manipulation. Spinal manipulation is generally accepted as one reasonable treatment option in the management of musculoskeletal disorders. Although there are indications that manipulation might be effective in some subgroups, as an example, patients with lower back pain and mechanical neck pain, the physiological mechanism behind the effect of spinal manipulation are not yet clear. Some evidence also exists that certain visual disorders benefit from spinal manipulation. Also, the mechanisms behind which spinal manipulation might alter visual function and so impact visual disease remains unclear. Somatovisual reflexes are often used as an explanation to how spinal manipulation could affect the visual system. The theory concerning the somatovisual reflexes maintains that efferent nociceptive signals generated by dysfunction involving various paraspinal somatic structures once having arrived in the central nervous system acts to facilitate the activities of segmentary related somatomotor as well as visceromotor neural cell bodies. This causes an increase in the autonomic activity and thereby affecting the segmentary correlated internal organs. The theory concerning the somatovisual reflexes is a debated topic. One cause of the debate is that mechanism of which spinal manipulation might alter visceral function is unclear. Another cause is that animal experiments show that sensory input from paraspinal tissues has the capacity to reflectively alter the neural outflow to the autonomic nervous system, and that certain visual disorders benefits from treatment involving spinal manipulation. The hypothesis which this study is based on is that high velocity low amplitude manipulation of vertebral segment T1 to 5 can affect the peak expiratory flow of the lungs. The lungs are innervated by the autonomic nervous system. The sympathetic innervation of the lungs derives from T1 to 5 sympathetic ganglia, and the parasympathetic innervation derives from the cranial nervus vagus, cranial nerve number 10. Stimulation of the autonomic nervous system will affect the diameter of the bronchi. According to some literature, activation of the sympathetic nervous system causes bronchodilation, and activation of the parasympathetic causes bronchoconstriction. One of the factors that can influence whether the bronchi are dilated or constricted is the tone of the smooth muscles in the airways. In classical view and in older textbooks, airway smooth muscle has a dual innervation, the parasympathetic and the sympathetic. Newer studies, however, write that the sympathetic innervation of smooth muscle does not exist or is sparse. The literature writes that the primary relaxant innervation of the airways is comprised of non-adrenic, non-cholinergic nerves localized in the parasympathetic nerves. The aim of this study is to investigate if there are indications that spinal manipulations can influence peak expiratory flow of the lungs. The method used to measure the change in the function of the lungs is measurement of the peak expiratory flow. A change in the peak expiratory flow would be expected if the tone of the lung smooth muscle is changed. Such a change could be caused by changes in the activity of the autonomic nervous systems, thus giving an indirect indication of changes in the autonomic nervous system. Factors that can influence the peak expiratory flow after manipulations are not only the autonomic nervous system. Also, the mobility of the thoracic spine can potentially influence the respiration. Manipulations are in manual therapy often used as a way of altering the range of motion of the joint. It could be suspected that such a change in the mobility of the spine can have an effect on the respiration. The muscle tone also seems to be affected by the manipulations of the spine. Change in the muscle tones could potentially affect the mobility of the spine, thus affecting the respiration. In this study, it is chosen to investigate a potential effect on an asymptomatic group with a normal lung function. If manipulation of T1 till 5 can cause a change in peak expiratory flow in healthy individuals with no cardiovascular problems, it would be relevant to do similar research on a symptomatic group with respiratory problems. Manipulation might have an effect on the quality of life and potentially lower the cost and side effects of the treatment offers to these patients. Studies regarding the effect of spinal manipulative treatment of patients with respiratory problems have already been done. These studies showed different results. The studies did not investigate what one technique applied to a group of patients had, but the treatment consisted of different interventions. This study, changes in peak expiratory flow after osteopathic manipulations of vertebral segment T1, T5, is based on the hypothesis HA. There is indication that high velocity, low amplitude manipulations of vertebral segment T1, T5 affects the peak expiratory flow. If the hypothesis HA is rejected based on the results, the following null hypothesis is accepted. There is no indications that high velocity, low amplitude manipulations of vertebral segment T1, T5 affects the peak expiratory flow.
30 test subjects participated in this study, 16 males and 14 females in the age 20 to 59. There were no control group. The inclusion criteria were that they were healthy and willing to participate, in the age 20 to 60 to secure full growth and diminish influence from arthritis, and the exclusion criteria were known diseases or damage of the cardiovascular system, known diseases or damage of the thoracic spine and ribs, and pregnancy. The testing procedure was done by the researcher, educated physiotherapist and 5th-year student at the International Academy of Osteopathy. Before the testing began, all test subjects were screened on the basis of the inclusion and exclusion criteria. Before the test procedure, the therapist went through an informed consent with the test subject. The informed consent was signed by the test subjects and the safety tests were done. The test included palpation, stretch, percussion, vibration, and compression test of bony, inter- and peri-articular structures, and urological quick test was also done. When the initial screening on the basis of the inclusion and exclusion criteria and the safety tests were done, and these did not exclude the test subject from participating in the study, the testing began. Initially, the subject's peak expiratory flow was measured with a peak flow meter. The peak expiratory flow measurements were done using a Pinnacle peak flow meter. The measurements were done maximum 2 minutes prior to the manipulation were performed. The measurements were done with the test subjects in a standing position and without any tight-fitting clothes that could affect the respiration. The test subjects performed 3 peak flow measurements before the manipulation. The highest of the 3 measurements were recorded in a spreadsheet. The manipulations were performed by having the test subject lying supine with his/her arms crossed. The researcher was standing on the side of the test subject. The researcher placed one hand on the back of the test subject. The researcher used a hitchhiker grip with bilateral contact on processus transversus of the vertebra below the segmental level which the researcher wanted to manipulate. The researcher put his chest on the test subject's upper elbow, then lifted the head of the test subject and supported the neck with the upper hand. The subject's thoracic spine was side-bended towards the researcher. The movement barrier was found, and the researcher thrusted on the segmental level in a craniolateral direction. This procedure was done on vertebral level T1 to 5. After the test subject was subjected to manipulations of vertebral segmental level T1 to 5, the peak expiratory flow was retested. This was done maximum 2 minutes after the manipulation were performed. The test subject performed 3 peak expiratory flow measurements. The highest of the 3 was recorded. IBM SPSS statistics was in this non-randomized experimental trial used to evaluate the data of a paired sample t-test. The intervention showed no significant changes between the pre and post measurements of the test subjects. The alpha level was set at 0.05. The p-value was 0.124. There were no control group in the study.
As a consequence of the results, the following hypothesis, H null, is accepted. There is no indication that high velocity, low amplitude manipulations of vertebral segment T1 to 5 affects the peak expiratory flow. The fact that the study showed no significant changes in pre- and post-measurements can be seen as an input to the debate concerning the somatovisual reflex. As the literature writes, the somatovisual reflex is a theory, and no study has shown clearly how spinal manipulations can affect the visual function. Even though studies have shown that sensory input from paraspinal tissues has the capacity to reflexively alter the neural outflow to the autonomic nervous system in animals, this does not imply that spinal manipulations on a human can alter the neural outflow to the autonomic nervous system. Therefore, further investigation on the topic somatovisual reflexes is necessary. The findings in this study, no significant changes in the pre- and post-measurements, also support newer studies. Newer studies write that the sympathetic innervation of smooth muscles in the lungs does not exist or are sparse. The literature writes that the primary relaxant innervation of the airways is comprised of non-adrenergic and non-cholinergic nerves localized in the parasympathetic nerves. The study can question the classical views and the older textbooks that write that the airway smooth muscle has a dual innervation, the parasympathetic and the sympathetic. One challenge in this study was that it was not possible to directly measure manipulation's effect on the sympathetic nervous activity. Such research requires a measurement method that directly measures the activity of sympathetic nervous activity after the manipulation. Such equipment would have increased the validity of the study, but was not available. The peak expiratory flow measurements can therefore only be seen as an indication of changes in the autonomic nervous system and not an exact measurement. The method used to measure the change in function of the lung is measurement of the peak expiratory flow. The peak expiratory flow was measured with a peak flow meter. The study has shown that the peak flow meter gives an accurate measurement of peak expiratory flow. However, the researchers who conducted the study experienced that some test subjects had difficulties using the peak flow meter. Some test subjects had difficulties expiring forcefully, which is necessary to get a measurement of the peak expiratory flow. In these cases, it was necessary for the researcher to take more than 3 pre-tests. The function of the musculoskeletal system has also to be taken into consideration. This study did not measure if the manipulations had any influence on the musculoskeletal system. Did the manipulations affect the movement of thoracic spines and the ribs, and thereby affecting the peak expiratory flow? In future research, it would be relevant to investigate what kind of influence the manipulations had on the musculoskeletal system. It was chosen to investigate a potential effect on an asymptomatic group with a normal lung function. The study indicated that it was not possible to significantly change the peak expiratory flow of the test subjects. It has to be taken into account that the test subject did not have any respiratory problems, thus their peak expiratory flow would be expected to be near 100%, and the expected changes in the peak expiratory flow could be minor. In future research, it would be relevant to investigate if it is possible to change the peak expiratory flow in a symptomatic group with a lowered lung function. It would be interesting to examine if potential changes in such a group would be greater and may be more easy to measure. This study had a sample size of 30 test subjects and no control group. Although opinions on sample size vary, it is usually considered that 12 to 15 subjects are the absolute minimum number required, and that sample size of 30 to 50 would be preferable. A higher number of test subjects would have increased the reliability of the results, and a control group would have strengthened the quality of the study. It can be concluded that the study showed no indication that high velocity, low amplitude manipulation of vertebral segment T1 T5 affects the peak expiratory flow. In future studies, it would be relevant, if possible, to directly measure the activity in the sympathetic nervous system after the manipulation and not only indirectly via the peak expiratory flow. In future research, it will be relevant to investigate what kind of influence the manipulations had on the musculoskeletal system and examine how these possible changes affected the peak expiratory flow. Further studies on a larger population are required to have more reliable results regarding T1 T5 manipulations ability to affect the peak expiratory flow.